Welcome back to the ResearchWorks podcast.
Yeah, welcome everyone. We're so excited that you can join us again this week.
Indeed.
And
Thank you.
today we have a wonderful follow-up paper from one of our previous guests who is now officially titled Friend of the Podcast.
Yes, I love it.
Come back more than once. Dr. Ros Ward. Welcome, Ros.
Thank you.
Welcome back.
And joining Ros, we have Dr. Neville Hennessey, who's also a co-author on the paper we're discussing today. Welcome, Neville.
Thank you very much. Glad to be here.
Oh, that's really cool.
Yeah, absolutely.
Well, it's always so wonderful when we can talk about the progression of one person's work, and a team of work. It's truly the spirit of collaborative research and sharing, continuing to build and just more knowledge about a certain area as well. And this is a great example of that.
Absolutely. Yeah, like you say, Dana, this paper is no exception. Today we're going to be talking to Ros and Neville about their article titled Implementation of an Early Communication Intervention for Young Children with Cerebral Palsy using Single Subject Research Design, which was published in the Journal of Clinical Medicine in December 2022. So I think we can say it's hot off the press.
Yes, indeed.
But before we get into the work, let's tell you a little bit more about our guests today. We'll start with Neville because you're our new guest, Neville. Neville Hennessey lectures primarily in the Bachelor of Science Speech Pathology program at Curtin University in the topics of speech science and acoustic phonetics, psycholinguistics, research methods, and statistics. Neville's research interests include dyslexia, psycholinguistics, stuttering, normal and disordered speech and language development, including the relationship between the emergence of speech and language skills in infancy and later language and literacy development, as well as the relationship between speech perception and production.
Wow.
I know, it's pretty impressive.
I love it.
Neville, just so you know, Dana always gives me the hard words to say in the intro.
Well, you've done well.
I do indeed. I'm very impressed. As you read it, I'm like, oh, she's done so good. I don't think I could do it.
And Dr. Roslyn Ward is a senior research fellow at the School of Allied Health at Curtin University. As a speech pathologist, Ros is well known for her work in motor speech interventions, particularly in the area of cerebral palsy. Her work has employed innovative assessment techniques and research designs such as single-case experimental design. In addition to this work, which has contributed significantly to the body of evidence for motor speech interventions, Ros has also contributed to the International Clinical Practice Guidelines for Early Intervention in Children with Cerebral Palsy, as well as the large cohort studies investigating early detection for cerebral palsy, which I think is pretty impressive.
Gosh, I love both of those bios. It's wonderful. Thank you, Ash. You did very, very well.
Thank you.
That was really good.
I think we can declare today another speechy takeover.
It is indeed. It's happened again.
Okay, Ros and Neville, that's the formal getting to know you. And now we like to do a bit of an informal getting to know you. So our icebreaker question for today is, what's the most interesting speech you've heard and why did it stand out to you? It's a tricky question, but we wanted to go with the speech thing.
I see what you did there. That was really good.
So I can get the ball rolling if you like.
Okay, yeah, go for it.
I don't know if it's probably the most interesting speech I've heard, but also one of the most wonderful speeches I've heard was the speech my dad gave at my wedding.
Oh, wow.
And the reason for that is because he has a complete fear of public speaking. This was, on paper, his absolute worst nightmare. He hates talking in front of people. He hates being the center of attention, but it meant so much to him to write this speech and talk in front of everyone about how proud he was of his family and, us becoming a new family. And it just meant so much to me because of how much effort he put into it and how much he had to overcome to do that. And that was,
so
cool. So that for me was the most interesting speech I got to hear.
Oh, wow. That's got it. Like, it ticks all the boxes really, doesn't it?
Yeah.
Like, overcoming, there's the courage to do that, but the love for you to do it.
Yeah. And I didn't cry when I said it. So there you go. Worked really hard on that.
That's why you went first. So you got
Get
this out of my cover. Well, shall we go to you, Neville? Do you have one in mind?
Well, when you mentioned speeches, I was thinking of the many types of presentations that researchers can give, and then I was going through my mind as to which one stood out to me. And there was one presentation by Daniel Kahneman, who's won the Nobel Prize in the area of economics. And I had the opportunity to see him present.
Wow.
Pretty soon after that, he'd won the Nobel Prize, and he gave an account of his large body of research. And his research, along with Amos Tversky, together they did some really influential studies of human decision-making and judgment that is now sort of impacting lots of areas like economics.
Yes.
And so anyway, that just really did stand out.
That would have been such a buzz to hear that. And just, wow, that's amazing.
Very prestigious
researcher. Yeah. What an opportunity to get to listen to him talk, such a pivotal moment in his career as well. There's nothing quite like the buzz you get from a great keynote presentation or something like that is there.
Yep. Ros, should we go to you?
When you first asked that question, I'm like, oh no, there are so many speeches to draw down on. Where do you go? Which one do you choose?
Yeah.
And I guess, and then influenced by listening to the speeches that have been remarkable for you both, I reflect on why we're sitting in this room now, how have we arrived at this place, how have I arrived at this space? And I guess the speeches, I find it difficult to identify just one, but the content of the speeches are the ones that are inspirational, that then to drive you on to make a difference. Yes. So be that from listening to speeches that have talked about how women have challenge the status quo and change things for us as women, through to listening to the mathematician who's made a big difference in the lives, I've forgotten his name right now, of young people who have then hated maths and then gone on to inspire others. So it's a little bit more diverse than one speech, but the theme of.
We'll allow that.
I like that. Well, mine follows really nicely from that in a way, because when I think of a speech, I think of one that was it was very influential, almost confirming for me. It was Dr. Dale Hull, and I heard him speak at Rehab Week 2017 in London. And it was just when I had the idea to start up Healthy Strides, and I was, just percolating and putting the ideas together. And he was telling a story about how he had basically set up NeuroWorks with his physiotherapist, and he'd sustained a spinal cord injury, and he told about, what had happened through that process and his rehab journey. And then he told this remarkable story about the creation of this amazing rehab center in the United States. And I'm sitting there with all this in mind already, and he said, so if you want to start a rehab center, all you need is one passionate physio. And I'm like, it's me. And I just remember, out of all the features that he picked to be able to carry something out, he picked passion. And I love that was the thing that came out, because that's where things need to start for them to be authentic. And that's the energy that you can that drives you even when times are hard. And I nearly fell off my chair for that one. I skipped out of there and I was bumping into people and I was like, la, 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 this is amazing. But it changed the course of things for me. So those are the influential speeches that can change the course.
It's like something out of a movie, isn't it?
It kind of
like
is.
He was speaking to you.
I could feel the camera zooming in on me, like da da da. It was one of those moments. I needed a voiceover.
Thank you, everyone, for sharing your story. Sorry to throw a curly icebreaker at you today, but
it's a good one though.
Yeah,
it was very
absolutely.
thematic. Yeah, well done. That's really good. Or should we get into it?
Let's do it.
Let's go. Okay, so let's tell you a little bit about this study. This study implemented an intervention protocol that was aimed at increasing vocal complexity in 3 pre-linguistic children with cerebral palsy. So 2 males starting from 15 months and 1 female starting from 16 months. This was evaluated using a repeated ABA case series design until the children were aged 36 months of age. Successive blocks targeted more advanced protophone production and speech movement patterns that were individualized for each participant. The data suggests that emerging speech production skills in pre-linguistic infants with CP can be positively influenced through a multimodal intervention focused on capitalizing on early periods of plasticity when language learning is most sensitive. There is so much to unpack here. Let's get started. I got myself one big word there, but I got through it.
Well done.
That's good.
Yeah. Okay. I'm just itching to get into the meat of this paper, but I feel like we should probably take a step back, start with some background.
Yeah.
So Ros and Neville, what do we currently know about communication impairment in young children with cerebral palsy?
What we know about communication impairment in children with cerebral palsy is that about 60 to 85% of children with CP will have a communication impairment.
Wow.
The communication impairment is going to vary in type and it's going to vary in severity.
Mm-hmm.
We also know that typically the communication impairment is chronic, which means that it has the potential to have long-term impact on activity and participation, from having basic needs met through to forming friendships and potentially educational success and employment. That information has been grounded in studies that have been done retrospectively through, for example, case audits and registries, and typically aimed at older children. So you asked about younger children. What do we know about younger children? And unfortunately, there's a massive gap in our knowledge for younger children. The work of Professor Katie Husted and her team at the University of Wisconsin-Madison are making a huge contribution into our understanding of younger children. They've been tracking children longitudinally from about 2 years of age, and I believe her data is now beginning to address the adolescent age span as well. That's how long she's been collecting data. And she's started to profile communication impairment and develop growth curves around speech intelligibility.
Wow.
So then between 0 to 2 years, what do we have? I think we've made a small contribution in that space.
Absolutely.
And hopefully we'll start to see more data in the coming years. So at the moment we know that it is possible to see deviations from typical vocal development at about 9 months of age based on a small sample size.
Yeah.
I mean, I find that surprising in a way, given how, the focus so much on early intervention and our knowledge around that and neuroplasticity. One of the reasons why maybe the research hasn't been so big in Sarah is because we focus so much on motor, like gross motor, fine motor at this early age, which is typically a lot of the goals when you often, when you're working with families. Is that a reason why? Because that's been so much attention to that area?
I believe so. And when we look at the work that's been done in the early intervention space, an amazing work that's being done, it's around diagnosis and identification, which it's principally a motor impairment. And so then moving forward, it's about dealing with those motor issues and about survival at times as well, so mealtime management. And so the emphasis on communication is not at the forefront. And potentially that's based around our knowledge of infants. They are pre-verbal. That's not the word I want to use. They're pre-linguistic. And so we're not expecting communication until they start to talk. And so you kind of think you can push it to the background. When in fact those early years, very early days, months, you're laying down very important foundations.
Which leads really nicely into my sort of next question. Well, look, the last time you were on, I for the first time, got taught about canonical and babbling and we talked a little bit about that in terms of the vocal, infant vocalizations. Can you just give us a bit of a rundown and just a summary again to refresh our memories? Because I think that's quite important for this, isn't it? Like, what do we typically see when it comes to infant vocalizations?
Well, infants quite an early age are learning the sound of the language, and from within the womb as well, they're starting to pick up aspects of the rhythmic pattern of the language that they're going to be exposed to. And so that they also explore with their vocal abilities, their own capacities, and that's starting at a very early age. And so what's been observed is that infants begin to vocalise in ways that reflect the control of their production of vowels, and then they move on to speech-like articulations. And so these vocal vocal patterns increase in complexity and become more speech-like that match the ambient language that they are learning at that point.
Yep.
And so those changes in their ability and the complexity, they've been referred to as protophones. So, and that can include various types of productions of, like, even raspberries, producing raspberries that require closure but pushing air through the mouth. That's important in being able to then formulate syllable production. So that's an early protophone for later syllable production. And then you have the more familiar babbling that you hear in infants. And same, bar, and da. So those sequences of a consonant and a vowel start to emerge. And that's before that they produce their first word. So this is all happening 6 over 10 months of age. They have a real emergence in these early speech patterns.
Yeah.
So you can see why that's important, right? Like you need to understand what that sort of process is before we even get to saying words.
Yeah.
I think that's the...
Yeah, and you need those building blocks. You need to go through that sequence of development to get to a point where you are able to form words. Is that?
Well, that's right. As you start to develop, as an infant starts to develop the capacity to communicate with intention, they draw on those articulatory skills and patterns and for their first words. So there's that transition. So these early vocal patterns are building blocks, and it's important that there's opportunity to lay those, to get those building blocks happening and available for their ongoing language development.
I guess some of it's breath control. Some of it is about coordination. And there's so much to coordinate. I mean, you only need to go to the dentist to have a filling. And you walk out and you're just like, I can't feel anything. I don't know what's happening. Your words, there's so much to coordinate. And when we put on top of that cerebral palsy, and you've got movement disorder, sensory, you put all of that into play. I can see how that process could be really shifted or look quite different.
Very social as well. So we know that the vocalisations that a baby gives to the people around them influences their behaviour, and then so how we respond to those vocalisations has an impact on that as well.
Yeah. And I was just thinking as well, you mentioned before, as we think of, cerebral palsy primarily as a motor disorder, but speech has such a huge motor component to it. So it's
that's right.
If there is that impairment there, that obviously has an influence on
skeletal muscle.
That muscle control. And I mean, it's obviously language and speech is very complex, but that is a component to it, isn't it?
And in fact, the literature is telling us from some of the studies that have been done in older children that the majority of children with cerebral palsy will have some motor involvement in their speech, even if it's not frank overt dysarthria, that there might be subclinical signs associated.
It's good to understand that.
And thank you for that beautiful overview. Now that we understand a little bit more about, I suppose we've set the scene, can you talk to us a little bit about what interventions might be available for young children, if you do identify that there is, an issue there that needs to be addressed with an early intervention kind of lens on it, what is available to support these children?
I'm going to answer that at two levels. Firstly, what's available for CP-specific interventions, and then what's available for under twos in populations that maybe are not CP but have speech and language difficulties associated with them. So in the CP, guess what I'm going to say. So we've got two systematic reviews. I think there was one that was done in 2016 by Chorner et al. And then the more recent review that you referred to earlier at the start of this podcast. There are no CP-specific interventions for speech, language development, communication in the 0 to 2 age range. So it's not until much older, which means that we're missing those critical periods. However, there is some literature.
A beacon of light.
In the space for younger children who are presenting with speech and language difficulties, either they're slower to develop or it's associated with other neurodevelopmental can I say disorders?
Yeah.
Such as autism spectrum disorder.
Yeah,
and although
sure.
they're different, there is a common theme that reoccurs through those, supported by literature around early development as well. And that is core elements of intervention. They need to address the parent-child interaction.
Sure.
We need to be responsive. We need to be goal-directed, and there needs to be coaching with caregivers.
Sure, yeah. So there's those real active ingredients and those principles that apply to everyone in that way. Yeah. That's really good to know. Yeah. So is that what you sort of mean by in this paper? I guess we're starting to go into the paper now, like a multimodal approach. Like, can you explain? Is that what that means?
So, yes, communication is multimodal. Look at it.
We're all waving our hands, which you'll be able to see on our video.
That's it. So it's not just vocal.
Yeah.
It is, we're using gestures,
Sure.
we're using eye gaze, we're looking at facial features, we're watching facial movements, we require hearing. So it's visual, it's auditory, it's sensory, and it's sensory motor.
Yeah.
And so in terms of multimodal interventions, we do know from work of researchers such as Choi, which I referenced in the article, that if you have if you are not given the opportunity to practice and experience across each of those modalities, then speech and language development will be constrained.
Oh, it's task specific on all levels, really, isn't it? Yeah, that's really important to actually draw out, because I think sometimes it's really easy just to go down one path, right? It's just all about words, but we don't communicate that way. You know, how many times do people get offended if you write a text without enough emojis in it nowadays to kind of go, I'm trying to express emotion, because there's more to it than just what's said.
Yeah.
Okay, so now shift to the actual approach, prompt. Can you talk us through what prompt actually is and what's the theoretical framework? What's it based on? Why do we do it?
So PROMPT is an acronym that stands for Prompts for Restructuring Oral Phonetic Targets.
I love prompts.
And I think most people who are familiar with PROMPT know it from the use of tactile kinesthetic input.
Yeah.
However, the theoretical is broader than that. It is multidimensional, it is multi-sensory, and it is grounded in dynamic systems theory. And I know that you're a fan of dynamic systems theory as well. And it's probably been a theoretical approach that has been foundational to rehabilitation within the motor sphere.
Absolutely.
So from a communication perspective, you know, how long you've given me, just a few minutes, I'm going to try and be really focused here, that what we're looking at from that clinical rehabilitation perspective as speech-language pathologists is that we're not grounded within that developmental perspective. We're looking at growth and development emerging from the interaction between the components within the system that you're operating and then the impact of experience and practice on that growth and development as well.
That's a great, for all those uni students out there who are learning dynamic systems theory and don't understand it, that was like the best definition you could probably give of it. That was amazing. That was brilliant, because and when you look at that in practice, it makes so much sense, you know, and it makes you sort of look out, makes you take that step out, I think, these theories. They make you sort of look at the whole context, which I really, really love.
Yeah, absolutely. So Bros, let's just talk now about how this intervention, I suppose, was trying to address that gap that we talked about before. How does prompt fit into this paper and the questions that you had around?
So I guess there's two key elements there, and that is the theoretical framework of dynamic systems theory. So you need to look at the components within a system and that opportunity for practice and experience for new behaviours to develop and emerge. So looking at the components within a system of communication, what the individual brings to the table in terms of their physical ability, cognitive linguistic ability and social emotional. So being able to evaluate what the balance is between each of those components. And then in terms of that multisensory element, being able to put strategies in place that facilitate the opportunity to have successful practice and experience to go on to develop really adaptive and functional communication skills within the daily routine of the child and what's important to the child and the family.
Yeah.
I guess what prompt offers as well, the second key component is that given communication is multisensory, there is the use of auditory, visual and tactile kinesthetic input to shape those behaviours.
Yeah. And I love it when you talk about all of those, I suppose, pieces of the puzzle that you're trying to put together. It really becomes very individualised for the child that you're working with, doesn't it?
That's right. So it does require you as a clinician working with the family to determine what are the strengths are, where there's not the balance that's preventing that integration.
Yes.
Do you need to be focusing more on building that social emotional awareness or understanding of routines or understanding of how communication works? That this vocalisation, for example, is communicative and shaping that. So it is unique to each individual.
Yeah. It's so fascinating, isn't it? And such, really interesting for you as the clinician getting to work with these families to try and piece all of that together, right? And work out where the strengths are, where they need extra support. It's
such a strengths-based approach.
Yes.
We talk about that a lot, and so often in developmental, approaches. Traditionally, it's all been about the fix it. We've been talking about that a lot on the podcast lately. It's the, what are the impairments that we need to fix?
Yeah.
And that takes us real sort of almost a negative view in terms of how to approach. But we're taking a strengths-based. What are the strengths of the child now, and how can we harness that to help them to develop and give them the best opportunity to do what they want to do? And I feel like that's really consistently across all the research now, and our practices.
Absolutely.
Yeah.
I guess, and what are the strategies that you could provide the child and the family with to maximise their potential?
I love it. It's really great.
Absolutely. So the aim of your study was to test the hypothesis that intervention starting before 2 years of age, framed within that prompt approach that we've talked about, will improve vocal complexity of children with communication impairment, secondary to CP. You used for this study, which I'm really excited about, a single subject experimental methodology, which we know by, a few other names as well, single case experimental designs. This is an incredible piece of work and and such a valuable contribution, I think, to the field. Can you talk to us about why you chose this study design specifically for this work?
Well, with the single case design, you're focused on the individual and bringing about change and in this case, progressing in their development in certain areas of interest. And so with that focus on the individual, that really matches the single case approach. And it's not just like a case study where you're looking and observing and describing what happens, but you're using more scientific rigour in the methodology in order to demonstrate that the treatment is bringing about the change. And part of the real essence of the single case design in doing that and having scientific rigour is being able to observe through repeated measurements a relevant target behaviour is what we call it, and over time, and you observe that under conditions where there's no intervention initially, and that's referred to as a baseline, and then you introduce the intervention in a controlled way. So this is where you're seeking to get experimental control by having the intervention in place and continuing to observe that behaviour and looking for change in the measure. And part of there are a number of reporting guidelines on how to conduct these studies to achieve scientific rigour and improve the validity of the results. And that can include being able to replicate the changes you're observing. And so we built that into the study. We had baselines, we had the intervention phase, and then we had a second post-intervention phase where we were able to then compare performance before and after, and that's essentially a way of estimating the size of the effect associated with that treatment or intervention.
Yeah.
And so we were able to replicate change by introducing the intervention through a series of 3 blocks of intervention phases, plus also across the 3 children. And so together those findings lend sort of support that the intervention is being effective. So that's sort of really why the design is a good one to use, and it's really appropriate for areas where the client or is unique in the term. So this is a heterogeneous type of effect on development, and so it's important to be able to focus on the individual and demonstrate that the intervention works for the individual and not just for an abstract group mean and that you find in clinical trials in group-focused studies.
Yeah. That was such a beautiful explanation of the rationale for why you would choose a single subject or single case experimental design. And that was a really important distinction you made, I think, between case studies and single subject research designs, because I think people who are less familiar with those might use those terms interchangeably, but they're really incredibly different. And single case experimental designs are incredibly detailed, incredibly rigorous. It's I think we saw firsthand, Ros, when you were in the thick of data collection for this paper, how intensive it actually is to make sure that you have collected that data in a way that allows you to draw conclusions, across each of those blocks that you are working with these children in.
It's phenomenal. So, I mean, for someone who's done SCEDs before, anytime you hear about other people doing it, you go, oh my goodness, I know, I understand. Yeah. But I guess the point for a lot of people is sometimes, we hear the criticisms of RCTs. We know RCTs are important on this higher level, but but if you have these very heterogeneous populations, really get into the detail, because it gives you time, which I feel like sometimes with RCT you have these set times, as in 1, 2, 3, if you can see on the video. And whereas this time you actually have graphs, you can actually see visually where things happen, and that in itself is a great way of analysing the data, isn't it?
Yeah.
Neville and I were talking earlier before this presentation, and my pet hate is the systematic reviews that put the RCT, randomised controlled trial, at the top of the pyramid and then report SCEDs as low levels of evidence and don't acknowledge the role they play and don't present to the reader, because these systematic reviews are supposed to be for clinicians to make a determination around which treatment to select, is don't acknowledge that actually if you haven't done research in this space before, you need to develop the protocol and you need to see how participants respond. And it does give you information that lets you know when the participant is responding, how long it took, what dosage response that you got.
That's right.
And so I'd really like to see systematic reviews acknowledge that space
100%,
rather than the level.
And I guess what's really unique about how you reported in this as well, which really drew my attention to it, was the procedural fidelity. Like you don't often, this was really unique. And I know we've spoken about fidelity many times before. I think every time we do talk, it's like, what about the fidelity? And, that's really important. So can you just tell us what you did to report on the fidelity? Because I think that's part of this process. Yeah.
So what we did, and you noted it, 50%. We went through 50% of the intervention sessions and coded. We identified what the active ingredients were and coded whether they were present, yes or no, and to what frequency. So that when we were interpreting the graphs, if we had a high level of response or a low level, if there was variability in the graphs, we could determine whether the variability was associated with the dosage of that session or whether it was around other potential reasons such as the child on the day having a bad day, or other reasons which potentially we can't actually determine, but we could actually look at that level of dosage. Did we do, not only did we deliver the intervention as intended, but was it at the dosage that was intended?
Yeah. So critical.
So important. Yeah. And I think because we don't report on that, how do we replicate it, right? So, even if you were to look at, I mean, it's not possible, well, maybe it could be, it'd just be pretty painful, but in a big RCT, you couldn't do that, into that level of detail sometimes. And I think that part, you take just a small sample out, whereas here you looked at such a big sample and you know what the intervention is. So that was
and
impressive.
It becomes so translatable to clinical practice as well. Yeah. So that's another real plus about single subject types of research, the translation
reduces that gap.
Yes. Yeah. And just on that note, RCTs obviously have a very important role to play in establishing the evidence.
That's right.
When we talk about the hierarchy of evidence, RCTs are up there, but often they play out in such a vacuum and you have to control for so many different things. This type of experimental design is, like you say, Neville, it's much more authentic to how you would operate day to day as a clinician and the kinds of things that you'd be looking at as a clinician who is delivering this type of intervention with and for this family.
Yeah.
It's a real window
really
into how,
really human.
Yeah, feels
really like.
much more. I don't want to say authentic, but it feels I suppose it feels more authentic to clinical practice.
Yeah. So before we go into the results, it's probably really important to know what you actually measured, so we can talk about that.
Yes,
so
yes.
Should we go there? Because I'm busting to talk about the results, but let's take that step back for a second. What's the target behaviour? And I know that you had probes as well, so you can just talk us through what did you actually measure? What was that intensive data collection? What was it?
So what we've reported in this paper and what you see on the graphs was the reporting on the development of their vocalisations.
Great.
So following an assessment period using standardised measures and then extracting the speech and coding the protophone, so the types of vocalisations that they were using, we then looked at the complexity of that protophone and how we would like to increase the protophone. So we did that embedded within daily routine, so at what was important to the family. So, for example, if it was a nappy change time, what protophone might be able to fit with that routine.
Sure.
If it was a play routine and enjoyed playing with particular types of toys, what would be vocabulary that would be associated with that? So we selected the vocabulary and then we selected what we expected they would be able to produce in terms of the protophone.
Sure.
And then as we progressed through the therapy blocks, we would review again pre-baseline, determine whether they were ready to go up to the next level of complexity in that protophone next, yes or no, to then wanting to arrive at being able to use single words.
Right.
So I do want to make clear too that we acknowledge that some children are going to be non-verbal communicators. It's not going to be their primary form of communication. So we also had other communication supports in place that we were focused on at the same time, but it's not the focus of this.
Sure.
And it really was around that opportunity for vocal play because of the power that has on later language learning and potentially access to AAC systems.
Sure.
Yeah, that's really important.
Yep, that's really good. Okay, so time to go into results.
Let's do it. Okay, so let's talk about the results in terms of the blocks that you went through with your participants. So that first block, which was around building the social routine and enriching the environment, talk to us about the results you had throughout that block.
So yes, that first block very much focused on building the social routine and that script around when we're doing this sort of activity, these are the turns that we take, this is the interaction between the caregiver and the parent, that real transactional nature of the interaction. And so the strategies were really focused around building that. So they were exposed to the vocabulary.
Sure.
So we predicted expected that we would see a little bit of growth, but because it was really about laying down and having the attention directed at the routine and the expectations around that and the transactional nature of the interaction, we didn't expect to see a huge change in their vocal behaviours in terms of slope and level.
Yeah, yeah. And was that the case? Is that?
And that was the case.
Yeah.
Yes.
Okay. Yeah.
Yes.
Yeah. So I think that's probably important to kind of tease out a bit for clinicians. Talk to us about, how important that block, I suppose, is when you are setting up, to deliver this kind of intervention with children.
So we, as you know, started. Some of these babies have been tracked from 6 months of age. So the intervention started in this motor speech space at 15 months. They'd gone through a transactional intervention at 12 months of age so that the families actually understood, following a child's lead, the strategies around responsiveness.
That sort of Hannon, I guess?
Yes, that's right, correct, Hannon. And then we moved into the home and really structured it around the home routine and what was important to the family. In terms of importance, that's our highest level of evidence at the moment that in terms of building speech and language development, that we need to have that transactional positive interaction. If you've got a baby who's vocalising at a level of pain or grizzling because they're not quite making the sounds and those vocalisations are not being responded to, then potentially those vocalisations are going to be shut down because there's not that responsiveness to it. And we
don't get
know.
the practice.
That's right.
That's right. Yes. Yeah.
I guess it's setting up that environment. We talk a lot about that enriched environment. What does it look like? Well, this is probably part of it, isn't it?
Absolutely. Yes.
Setting the scene, people in, important people in the child's world, understanding and supporting and having some strategies in place, I suppose.
That's right.
Which I feel like anyone could do, as in like we can teach anyone to do that. So whilst you might be waiting, because we know there's wait lists, right? So whilst there's wait lists, we could still be doing this. Not a lot of resources.
And
I think, in terms of transdisciplinary, I'll try that again, edit that transdisciplinary or multidisciplinary or whatever, when you're working together as a team and you've got one family with so many demands, this is something that can be embedded when you're stepping on a treadmill or when you're doing a nappy changing routine. It doesn't have to be
speech time.
Necessarily. And the takeaway I had as well, rightly or wrongly, is that while you might not be seeing huge changes or any changes really in that initial foundational period, it's still a really critical period to then build on in the subsequent blocks that you go through with that child, isn't it? So
absolutely,
don't pie the building blocks.
And it's a slow, gradual process, isn't it?
That's it. And it is that raised awareness around what is the role that these vocalisations, that this little person is giving. What is the role of these vocalisations? What is being communicated to then respond to those vocalisations? So I can hear you're in pain. You're uncomfortable. You're telling me.
It's tuning in, isn't it? It's just being aware, tuning in, hearing it, acknowledging it, and actually realising it's important. And there's a process to it.
Yeah, and that you hear them.
Okay, so that's block 1.
Yep.
Tell us about block 2 and 3. Broadly, but speak to that because I'm excited.
Block 2 and 3 is where we moved into the motor speech space more directly. So the foundations were laid down and we used the tactile kinesthetic input to then shape the vocalisations, to increase the complexity of the vocalisations. And so we also had language around what sounds that they were making, how to make those sounds and supporting them with the production of those sounds.
What was the frequency of the intervention, I suppose, through this? I don't think we've covered that part yet.
Well, home visits once a week.
Home visits once a week,
and the therapy was structured, it was about 45 minutes with 30 minutes hands-on with the child and the rest of the time spent with the family, talking about how the previous week went, what was going to be the focus of the next week.
Yeah.
Plus, you also have to make allowances for collecting doing the probes.
Yes.
Yes.
And so we can measure and track change.
Yeah.
So how many weeks was that in total for block 2 for the intervention?
So the intervention blocks were 10 weeks.
10 weeks.
Yes.
Yeah.
Wow.
Yeah. So 10 weeks
why
of
you're
home
so
visits
busy.
and then, as Neville said, staying on to collect
point
the
in saying
data
that.
afterwards.
Yeah.
So we were there longer than that. The
Yeah.
probes got easier as time went by.
Yeah.
Okay, so what did you find as a result of these intensive?
Chips.
Yeah.
Can you remember all the results? Because there are a lot of results with effect sizes and so on. But basically what we saw is that we had that increased progression in skill development.
Yeah.
So and it depended again, that's why it was nice, single subject design, looking at the individual participants, because we also had children who had spastic CP and ataxic CP.
Yeah. Right.
And so we could see that that third block was really necessary the second block was really like, okay, I'm moving into, I'm having control, I'm starting to develop control. Third block, it's being laid down now, whereas other children was like that really progressive increase. I think for one of the participants, if we'd stopped at block 2, we would not have got the progression that we would have liked. So
that's important information, isn't it? It's when you're planning, when you're actually, within the context of any family wanting to sit down with their therapist to sort of plan, okay, what does our year look like?
Yeah.
Because they're busy lives. You're talking about young people, busy lives, probably sleep is a factor, a lot of things to think about, probably nutrition as well, a lot of appointments. So what does it look like? Well, I think it's good and fair to say that sometimes some kids might take this amount of time, but others it might take that 20 weeks, might take a longer period of time. But it's important to know that so you can plan for it, right?
And I think that's what single subject design gives you again, isn't it? With that post-treatment phase, you can see whether they were maintaining yes or no, or whether they were continuing to develop skills. So I'm a firm supporter of breaks from intervention, planned breaks from intervention for consolidation and just being a family.
And being able to monitor through measurement. And so taking measurements that allow you to gather information about how the development is progressing is very important.
100%. I feel like we just spoke about that before.
Yes.
As I was showing Ros around, I was like, we need to make sure, because it's so easy to make assumptions based on clinical experience. And that is valuable. Absolutely, it is valuable. But remembering that if we keep talking about each person being so individual, well, how do we make that decision for that person rather than make an assumption, measure and make your recommendations based on that? And the brilliant thing about single case designs is you can measure things that are very individual, at least have that to track them. And but breaks, we love that. We've been hearing that a lot lately.
We have,
haven't we?
It's very consistent with what we talked about with Andrew previously, and that consolidation phase of learning is critical. And when you are engaged in blocks of really intensive therapy and you do that on an ongoing basis, there isn't really that chance to consolidate all the things that you're learning, particularly for those really young plastic brains.
That's right.
And I think we move in and out of the priorities with the families as well. So I know one of the little people in our study, we did have that intensive focus on vocal productions and that intention behind communication. And then a long period on being successful with AAC and then being set up to go into the educational setting and then coming back into the vocal development again.
So vital. So I guess what does this mean for clinicians? Like the results that you have gained from this amazing study, what can clinicians take away from this?
Get in early. Capitalise on that neuroplasticity and those pathways that are being laid down right from the get-go, very early. Work with your team to have really functional, goal-directed intervention. That includes laying the foundations for vocal development for later success with communication and have fun.
Love it. Yeah. No, that's really, really vital. And I think that's an important piece of it all, isn't it? To go fun is actually part of it, because that's life. And kids should be having fun.
It's one of the F words.
It's one of the F words.
Yeah, absolutely.
No, we're really consistent with the messaging here now.
Yeah.
In a way, the study is exploratory, and it's really the first study that I am aware of that has demonstrated that you can get in at that younger age and bring about some change or improvement in those vocalizations. So, this is an early stage of the research, and we would be interested in going further to look at longer term benefits of that change. But just being able to demonstrate that you can get in there through an intervention of that type to increase the complexity of vocalizations in a therapeutic way is what the research is what's quite unique about it. I think.
It's wonderful.
It's such an exciting space to be working in, and I know for both of you this has been a lot of work, but I think, I don't want to put words in your mouth, but I think you would say it's been, rewarding work, and you've made such an incredible contribution to this field that is, crying out for more evidence in this space. So, I thoroughly enjoyed reading this paper, and I'm looking forward to what comes next. Do you want to tell us a little bit about what you've got? Where to from here? Where's this work taking you? Or the other things that you've got going on? Where to next?
We've got a number of papers in semi-prepared state
nice,
with a data set that we've continuing to analyse. So watch this space for those papers hopefully in the next 12 months.
Fabulous.
And then really the intention is getting more grants to actually scale up, looking at the outcome measures as well, ways that are easier to collect the data than the intensiveness of the analysis that was required, which Neville, your app, maybe. But easier ways to actually extract and analyse the protophones would be is what we're looking at as well.
And that's that real translation into clinical practice, isn't it? Making it accessible for clinicians to pick up and use these assessments. And
that's part
absolutely.
of it. Well, I mean, thank you so much. I feel like I learned so much in that process. I feel like I said this about every podcast, but when I learned so much more about this, I know that we can put this into practice because I think the main message you put out there is something so tangible and we can do it. And I feel so inspired by that. So thank you so much for taking the time out to speak with us about this and sharing your knowledge. And remember, to all of our listeners out there, if you want links to where you can find the paper, our show notes, head to our website, researchworks.net. And there's a link there to the CPD form as well if you want to keep this part of a record of your PD requirements. It's all there.
It's all there.
All there.
And Ros and Neville are going to be very busy, so it sounds like they need a regular segment on the show to come back and talk about all these papers.
I know.
Oh, thank you very much for your interest in having us today.
Yes, thank you.
But we're incredibly grateful for your time today. So thank you both for all of your knowledge and for being, willing to share that with us and all of the listeners.
So generously too.
Yeah.
Well, thank you for having us today, because it's through events like this that the information gets out there. So thank you.
It's a pleasure. Absolute pleasure.
You. Yes.
Well, to all of our listeners, we'll talk to you all again next time. Thanks for tuning in. Bye.
Bye.